session 2, focusing on metabolic-associated steatotic liver disease. My name is Yusuf Yilmaz, and it's a privilege to co-chair this session with, alongside with my esteemed colleagues, Professor Halis Şimşek. We have a very tight and comprehensive schedule ahead of us, covering the latest updates, screening strategies, and patient care, followed by real-world case discussions. To kick off the sessions, I would like to invite Dr. Amina Bansal to the podium. She will be presenting the TLM debrief on MESLT, giving us the latest insights from the liver meeting. To conclude, I would like to present Dr. Bansal's bibliography. Dr. Bansal has been on faculty at Mount Sinai since 2001. In addition to maintaining an NIH-funded research program focused on molecular mechanism of liver fibrosis, Dr. Bansal held many different leadership roles at Mount Sinai, including transplant hepatology, fellowship director, director of translational research, medical director of hospital-based clinics, chief medical officer of Mount Sinai Care, deputy chief of medical officer for Mount Sinai Health Partners, and vice president of population health for quality and efficiency. From a clinical perspective, she is currently focused on treatment and management for those with MASH. She has served as principal investigator for numerous clinical trials for MASH and has been greatly involved with bringing therapeutic patients. At international levels, she had the position of Secretary of AASLD, served as the director of newly formed MASH Center of Excellence at Mount Sinai. Most recently, in 2024, Dr. Bansal was named System Chief, Division of Liver Disease for the Mount Sinai Health System. Without further delay, let's begin. Dr. Bansal, the floor is yours. Thank you. Microphone, please. You need to press the button.
Good?
Yes.
Okay. All right. Thanks very much for that kind introduction. Keep in mind that many of these things were already presented at the liver meeting AASLD, presented by my colleague, Dr. Siddiqui. So I appreciate the ability to leverage those slides. So for those of you who were not at the liver meeting 2025, MESLT at a glance. There were 630 abstracts, 45 oral presentations ranging from basic science to clinical research, more than 1,000 unique authors from undergraduate to senior scientists with global representation. There were presentations that focused on multi-specialties, multidisciplinary approaches, industry to academia, and global consortiums, and kind of takes us through the clinical journey, deeper understanding of disease impact, disease awareness, screening and risk stratification at the patient level as well as therapeutics, and then risk stratification for predicting decompensation and mortality. So when we think about global mortality trends in MESLT, data from the Global Burden of Disease 2021 database, they looked at MESLT-related age-standardized prevalence, incidence, and mortality. And from 1990 to 2021, both the prevalence and the incidence increased more in females, and mortality increased more in males. Importantly, by 2050, both the prevalence and the incidence are expected to increase in most in Eastern Mediterranean regions. And I learned at dinner last night, when you think about Turkey, you have to think about it itself as having its regions. And so central Turkey seems to be the hot spot for MESLT. And so we're going to expect that we have to have a more concerted effort to change that trajectory by focusing not only on the liver, but non-liver related complications such as cardiovascular disease and malignancy. Now, we know that the overall mortality trends are increasing, but what is making them up is also changing. So MESLT-related premature mortality has tripled, but importantly, cardiovascular disease still is the leading cause, but declined from 24 to 15%, while malignancy, including extrahepatic malignancy, increased from 2 to 6%. So it's important for us to incorporate cardiovascular disease risk stratification and care and standard of care cancer screening such as mammography and colorectal cancer screening in the clinical management of these patients to improve overall survival. Now, early detection is critical to impacting these mortality trends. We know that patients get imaging for a variety of reasons. And so leveraging a deep learning algorithm, colleagues at Stanford assessed 19,000 patients who had CT scans for completely different reasons. And they identified 28% with steatotic liver disease compared to 20% that were diagnosed on radiology compared to 4% on ICD coding. And I'll come back to the problem with ICD coding in the next presentation. Next slide. So utilizing imaging allows us not only to pick up potentially misdiagnosis and improve patient care, and also increase awareness and therefore improve detection of patients who may be living with this disease. So I mentioned ICD-4 coding and how kind of problematic it is, and this study kind of focuses on this as well. They looked at the Trinetics Global Collaborative Network, which includes 146 million people. They then compared what was the prevalence of MASLD or MASH in the Trinetics database, what was the prevalence in the UMass database compared to what would be expected. And you can see, even in the high-risk populations of diabetes and patients with a BMI greater than 30, there's a significant loss of identification of patients based on ICD coding. And that has real implications, not only for the underdiagnosis in terms of clinical care, but can impact our research in terms of us looking at trends, feasibility, and also in guiding hospital policy for allocation of resources depending on the burden of disease in our own institution. So much work to be done there. And as Ada pointed out in her talk earlier today, many of the societies have aligned on this kind of FIB-4 as a first line of defense as a rule-out approach. She made that point many times, and I'll emphasize it here. This is really a rule-out approach, less of a rule-in approach. So there were a couple of studies looking at how are we doing when it looks at using this algorithm in real practice. So in this case, they looked at 56,000 patients in primary care, and they stratified them across with their FIB-4 band. So 73% would be low risk, 20% intermediate, 7% high risk. Interestingly, in that first panel, the hepatology referral rates were very similar across the FIB-4 risk categories. However, hepatology visits, those who actually went to hepatology, were higher among those who had a high-risk FIB-4. If they were seen by a gastroenterologist or an endocrinologist, that increased the chance that they would go on to have a liver stiffness assessment and be referred to hepatology care. So while incorporating FIB-4 referrals has not been fully adopted, and specialized practices with higher awareness are more likely to refer, so much work to be done there. Now, can we refine screening even further in clinical practice? In this study, they looked at the NHANES data in an effort to identify clinical parameters associated with having a liver stiffness greater than 8 kPa. They divided them into diabetes, no diabetes, metabolic risk factors on the y-axis there, weight status on the lower end, and the two horizontal bars are divided up if they had an elevated ALT greater than 30 or an ALT less than 30. And when they did this, they looked at those that had low liver stiffness, those in green, included. So among those with diabetes, if you also had a low ALT and you had no obesity, you had a low risk of having a kPa greater than 8. If you didn't have diabetes and you had a low ALT and no obesity, then that was the case. So we may be able to refine a little bit on our population to reduce patient and provider burden of the screening pathway and anxiety. So from a provider perspective, how can we help primary care screen? In this study, this was looking at the adoption of an EPIC smart phrase, FIB-4, which would automatically calculate the FIB-4 in the electronic medical record, and then FIB-4 more, which then also goes on to do the interpretation with elastography. And when they implemented this education, baseline screening rates went from 4 to 59%. The problem is the fall off after that. So you do the screening, but then kind of the waterfall of getting the next level testing and ultimately referred to hepatology requires a lot more. So templated notes and smart phrases can be used to increase awareness and screening, but there remains a big gap in incorporating that knowledge in clinical practice. Now, what about a more population health approach? In this case, they took primary care patients with both diabetes and obesity, 7,000 patients. The group calculated the FIB-4 and then fed the PCPs a prompt for those that required further evaluation. So of that group, 430 patients would need a referral for second level testing. And of those, only 50% were then actually referred. So that's the big drop off. So we're telling you, you refer, 50% then went on to refer. And then if you look at the drop off, then there's another 50% drop off on those who've actually gotten the FibroScan completed. Of those who actually got it done, 25% had significant fibrosis. So I think these things are helping, and I would say I'm a glass half full rather than glass half empty. We just need to start to keep having this conversation. The more people are screened and the more physicians see that they are detecting patients with advanced fibrosis by doing this, they will then start to do it more. So we know that cardiovascular disease is the leading cause of death in patients with AASLD, so we need to also think about assessing the risk in our patients to provide a more holistic approach. So Life Essentials 8 was developed by the American Heart Association, and it assesses individual health behaviors such as exercise, diet, sleeping, nicotine exposure, as well as clinical parameters such as lipids, blood pressure, weight, glucose. And what they showed is that poor or intermediate score, so each of these is scored on 0 to 100, and then it's averaged. So 100 is great, and anything lower than that is poor. So poor or mediate versus ideal LA scores had a significantly higher predictor of cardiovascular outcomes in patients with AASLD. And so poor health behaviors link AASLD to cardiovascular outcomes that are independent of traditional metabolic risk factors and reinforces the importance of healthy living. I thought this was very interesting. So this was a study out of India where they randomized 119 patients to diet and exercise or diet and yoga. And what they saw is that there was improvement in insulin resistance at 6 months, both in the diet plus yoga group and the diet and exercise group. The point is that do what patients will stick to, and so low intensity interventions can also help, and therapy should be catered to patients' ability. Now, what about late night eating? So this is an analysis from the Nurses' Health Study and Health Professionals Follow-Up Study, and the outcome was physician-diagnosed incident cirrhosis and self-reported MASLD. There were 200,000 participants, of which there were 312 incident cases of cirrhosis and 4,500 incident MASLD. In multivariate analysis, late-night snacking was associated with an increased risk of both incident cirrhosis and self-reported MASLD. So late-night snacking may be low-hanging fruit, no pun intended, to help patients mitigate MASLD cirrhosis risk. So we know that semaglutide was FDA approved for the treatment of non-cirrhotic MASH in August 2025. And we also know that GLP-1 receptors are not thought to be expressed in the liver. Therefore, the effects of semaglutide on MASH are thought to be predominantly due to weight loss. So in this study, they wanted to separate out and see what could be weight loss dependent versus independent effects. So they looked at improvement in clinical outcomes, ALT reduction, histologic response, and liver stiffness, and using logistic regression with percent weight loss as the mediator and treatment as the exposure. They found that in all cases, while there was a weight loss dependent effect, there was also a weight loss independent effect. And MASH resolution rose from 48 to 71% across all the weight loss bands, so less than 2% all the way down to greater than 7%. Now, that there was a preservation of the estimated difference in that responder proportion, but nevertheless, semaglutide confers weight-independent liver benefits with further improvements proportionate to weight loss. They did not comment on whether there were changes in insulin sensitivity, which could be driving that. So we know that saraglitazar is a PPAR alpha gamma agonist, which is approved for the treatment of MASH in India. And we know that women living with PCOS have an increased prevalence of MASLD and MASH. So this was a double-blind, placebo-controlled randomized trial looking at saraglitazar versus placebo. 30 women were randomized for 24 weeks. Saraglitazar was well tolerated, and as you can see, saraglitazar improved hepatic steatosis as assessed by a 30% reduction in MRI-PDFF, as well as improvement in lipid parameters. There was no effect on androgen excess or ovarian function. Now, the FGF21 class is probably one of the most promising emerging classes of drugs for MASH. And FGF21 is an endogenous hormone that has a number of effects on glucose and lipid metabolism, but it has a very short half-life, only 2 hours. So all of the medications that you see are kind of a modulation to that FGF21 molecule to increase its half-life. So the molecule that's furthest along in clinical development is efexafermin, and this is a phase 2b symmetry trial in F4 cirrhotics. There were 181 patients, and they were looking at fibrosis improvement by one stage without worsening of MASH at 36 and 96 weeks. While it did not meet that endpoint at 36 weeks, at 96 weeks, 29% of patients in the 50 milligram arm had fibrosis improvement compared to 11% in placebo. Small numbers, we await the phase 3 studies, but this is the first time that we've seen a pharmacotherapy reverse cirrhosis by that one stage. And then at the liver meeting, kind of one step further was presented. So this is again that same clinical trial population. Here now the outcomes were a shifting in Bovino criteria for clinically significant portal hypertension or a 20% reduction in Agile-4. And as you can see all the way to the right in the efexafermin 50 milligrams, you see this shift of less patients in the treatment group having criteria that meet clinically significant portal hypertension or probable clinical significant portal hypertension. Also, they didn't show it in the graph, but they also had a larger reduction in Agile-4, 64% compared to 42% versus placebo. So very exciting around the potential therapeutic options to treat MASH cirrhosis and portal hypertension with pharmacotherapy. So what about disease progression in patients with diabetes? How frequently do we need to monitor? So this was a study of 1,500 patients with diabetes in a real-world setting. Patients were categorized by the 3 bands of fibrosis: low risk, less than 8 kPa, intermediate, and high risk. They were followed for 2.5 years, and only 4% moved from lower to a higher risk category, and that was associated with age, diabetes duration, BMI, hemoglobin A1C, and GGT levels. So while good clinical therapy will lead to improvement, small percentages remain at risk for progression, underscoring the need for continued surveillance. Now, in this study, they looked at a large cohort of patients with type 2 diabetes in Hong Kong, and they established 3 hemoglobin A1C trajectories at the time of diagnosis and following up for 5 years. And they followed their hemoglobin A1C, and they were categorized as mildly decreasing, increasing, or rapidly decreasing. Those with a hemoglobin A1C greater than 9% had a higher risk for decompensation, but those with rapidly decreasing hemoglobin A1C had protection or lower risk, while those with rapidly increasing had higher risk of liver-related complications, underscoring the point that we as hepatologists need to be a part of that initial control of diabetes, as it may reduce the future risk of hepatic decompensation. Now, this was a very interesting study looking at changes in clinical parameters to predict liver-related events. This was a multi-center study of about 2,400 patients. They all had a liver stiffness greater than 8 kPa. And then patients underwent repeat FibroScan testing at 1 year. And they were categorized as those that had a reduction in their ALT of 17 or a liver stiffness reduction of at least 20%. They were followed out, and you can see in the red all of those at 5% risk of a liver-related event at 5 years in those that had no reduction in ALT, nor did they have that reduction in liver stiffness by 20%, compared to the purple that had both the ALT reduction and the reduction in liver stiffness. CAP did not affect the risk of liver-related events. So when you see patients having both liver reduction ALT and liver stiffness, that is a good sign. And lastly, what about the risk of decompensation MASH cirrhosis? Most of the data describing kind of year to decompensation comes from clinical trial data such as STELLAR-4. So this was looking at a real-world cohort, 44 databases of patients with compensated cirrhosis, and there was a 24 to 27% of patients experienced a clinical decompensation event by 6 years. So this real-world data suggests a higher risk of hepatic decompensation in patients with compensated MASH cirrhosis, though optimal approaches to mitigate this risk, obviously, we're working on it, not well defined yet. So the key takeaways from the annual liver meeting: improved knowledge on epidemiology around the world, strategies to improve screening and referral through primary care, novel NITs and optimization of currently available NITs, pharmacologic therapies and assessing response to therapy. Non-pharmacologic therapies cannot be underestimated and forgotten, such as exercise, yoga, diet, and kind of real-world risk of decompensation in patients with MASH cirrhosis. Acknowledgements to TASL for having us here, all the organizers, Dr. Siddiqui for doing the TLM debrief at the liver meeting. Thank you.
Thank you, Dr. Bassi, for that comprehensive update and for setting the stage for our session. We will take the question at the end of the session.
Dear colleagues and friends, we thank TASL and AASLD very much for their great support and for bringing us together for this important meeting. Especially thanks to Dr. Kim and Dr. Idilman make these meetings possible. I am happy to invite our second speaker, Dr. Ray Kim. You all know him very well for years, no need for introduction. His topic is screening muscle D, evidence-based approach. Buyur, please.
Thank you. Good morning, everybody. I'm kind of a filler between two important talks. So not as data intense, I hope to provoke some thinking in you as we think about what we recommend our primary care colleagues about MASL screening. So I'm going to address three topics. Why do we recommend screening? Who do we recommend screening? And how do you screen those individuals? And what are the evidence for that? So I'm going to tease you a little bit with questions. Which of the following screening tests has been shown to save lives, lower mortality by high quality evidence? Who says mammography? Some. Cholesterol in terms of cardiovascular risk? Yes. Colonoscopy? Larger number? Anybody? FibroScan? Okay, so that is the point. The strongest data that I could easily find was colonoscopy, and this is a Nordic trial. It still had some controversial result, but it showed that if you randomize people to screening colonoscopy versus not, there was a benefit in terms of reduced cancer risk. It took 85,000 participants, followed for 10 years. Should we have that? That's the evidence that will drive the field and encourage our primary care docs to believe that what we preach really bears fruit. So should we have MASH screening RCT to show reduced liver mortality? Is that possible? Is that ethical? So right now we don't have that, but we do have bits and pieces along the way. So first step, we have some evidence that MASL screening leads to early diagnosis of MASH before they develop cirrhosis. You just heard that we might be able to reverse cirrhosis with pharmaceutical therapy in the future, but the impact of that is smaller compared to the situation where we can find people before they develop cirrhosis and intervene early. That's the gold standard. Then we have effective treatment in non-cirrhotic patients that we can reverse fibrosis. So that's the second step. And then we can argue that by preventing cirrhosis, you can reduce liver-related mortality. These are logical steps, but evidence medicine doesn't work by logical steps. They demand randomized trials, so you know. So important part of this continuum is fibrosis. So as you know, when we screen for people, we look for fibrosis, and the endpoint of treatment trials so far is in part fibrosis. So an important sort of a link that connects these dots. So what evidence is there that screening leads to earlier diagnosis? And the only randomized clinical trial that I found, or I am aware of, is this trial from Vincent Wong's group in Hong Kong, where he randomized type 2 diabetic patients 18 to 70 years of age in primary care clinic and no prior liver diagnosis. He randomized about 1,000 patients, and one group received intervention, which was FIB-4 or APRI, auto-calculated, and then if the score was high, they were sent for FibroScan. The other was standard of care. They didn't get that intervention. The primary endpoint was whether transient elastography was done. And voila, the big difference. So if you do the screening, we do more testing, and when we do more testing, we find more people with fibrosis, as one of the abstracts showed in Dr. Banzel's review. So this is evidence that screening leads to earlier diagnosis. I will come back to this data in the next section. So with one piece of data, what I can summarize, why do we screen? Screening is only meaningful if it leads to a difference in patient outcomes. And how strong data do we have? There's no hard data for AASLD, and that should spell to all of us that there's a lot of room for research. It's not too late to think about ways to demonstrate benefits of what we do in our patients. Fibrosis is a key surrogate for prediction of survival and treatment endpoint, as you know. Fibrosis is a screening target. Treatable MASH, I think, is critical today. Prevent cirrhosis with available treatment. The problem is there's a long latency before hard endpoint occur. And then, as you just heard, the progression rate is not uniform. So linking reversal of fibrosis at stage 2 and 3 to reduce the mortality, that is still a lot of a variability there that we need to go out and demonstrate with data. Screening for advanced fibrosis and cirrhosis is still meaningful, right? You want to find these patients so we can do surveillance for portal hypertension and liver cancer. But in terms of public health, reducing mortality, the impact of that is going to be smaller, especially when we don't have available therapy to reverse cirrhosis. So there is a rationale for screening. We kind of know what to look for, but there's a lot more research to be done. Fair enough? Okay. Next question, who to screen? This is a malicious question that I'm going to ask you. Which of the following data should trigger screening? Raise your hand. Platelets 120. Is that part of screening criteria? How about triglycerides of 148? Is that high enough? Waist circumference of 93. Then you have to ask a question about that. I'll come back to that. A1C 5.6, is that high enough? Blood pressure 130/82. Okay. So I'm just badgering you with these questions. But the point is, no one remembers these numbers, especially if you're a busy primary care clinician that needs to do 30 different screening tests from mammogram to pap smear and different things. No one remembers these detailed numbers. So look at this, CMRF, cardiometabolic risk factors. Waist circumference 93 is abnormal if you're a woman, but not if you're a man. Again, this is a detail that matters. It shouldn't matter that much, but it matters if you want to apply the rules in your practice, and so forth. So that's the point that I'm making, that this is too difficult, too complicated. And to make things more interesting, if you look at the different society recommendations, these are the summary. Type 2 diabetes, in all the societies, they recommend to screen for MASL. But after that, there's a lot of variability. So AGA says you have to have 2 of those cardiometabolic risk factors, or steatosis or ALT. AASLD, we don't have a discrete our own, but we sort of dovetailed with the Endocrinology Society. Pre-diabetes is in, obesity in, and so forth. ADA, American Diabetes Association, has something different. AASL has something different, and AASLD has something different. So if you're a primary care clinician, which one do you follow? I'll come back to this one. So type 2 diabetes is common. So they are in. Then what about non-diabetic population? Who do you screen? Do you remember all the cardiometabolic risk factors? This is data that we submitted to AASL, looking for fibrotic MASH, which is a term that we define with FibroScan over 8 with a CAP 275, or FibroScan over 15 regardless of CAP. We looked at NHANES data in 7 million people with fibrotic MASH. So the prevalence of fibrotic MASH in obese individuals, non-diabetes, is about 10%. And when that obesity was defined by BMI alone. And forget the waist circumference complication. But if you follow the all obesity criteria with BMI and waist circumference, that goes down to 7.4% and so forth. So if you're just overweight, the risk is 1.5%. The guidelines do not differentiate between these risk factors. They say 1 or 2 in combination and so forth. That is still very complicated. So we decided to make it simple. Can we make it simple? And KISS principle, that last S is not steatotic liver disease, but I borrowed it. And can we make it simple? What if we just did type 2 diabetes and obesity simply defined by BMI? This is what you get from the NHANES data. Of people with fibrotic MASH, 47.5% have obesity alone. 8% have type 2 diabetes alone, and 37% have type 2 diabetes and obesity together. It leaves only 7% of people who have none of these risk factors, but have weird combination of the CMRFs. So if you just went out and look for people with BMI over 30 or have type 2 diabetes, you cover 93% of people with MASH. What's wrong with that? That's my argument. So we compared that with other guidelines. So the top line is the KISS principle, type 2 diabetes and obesity. You get 93% detection by testing 49% of the population. So that's a very large number, but that's what you get in the population. If you added hypertension, it goes up to 98%. So that's pretty good, but then you have to take 60% of the population. The worst is AASL criteria, in my opinion. You get only 74% because they have overweight in the mixture, and you end up testing 74% of the population. So that's not very good. If you do AAC, AASLD criteria, you do cover 100%. You find everybody, but you have to test the 90%. You might as well universally screen everybody to do this and forget about the CMRF counting. So this is reality. We need to be uniform in our recommendation to primary care docs. We can't be like 10 different recommendations and yell at them for not doing the screening. We need to get our act together. So that, how to screen? Again, I'm making this a bit artificially difficult. So you are asked to do a colonoscopy in a 55-year-old person for a screening purpose. In reviewing the chart, you note that he has had diabetes for 5 years. His BMI is 32. His platelets 202, AST 33, ALT 49, albumin 4.1, total protein 6.9, total bilirubin of 0.7 by Jaffe method. Should you order elastography? Who says, I'm going to do FibroScan in this person? Okay. Who would not do FibroScan in this person? Okay, why not?
I have to take 5 tests. 5 tests. After that, I have tests.
Yes. Yes, so that's exactly the point. And I manipulated these numbers so that FIB4 is 1.28. Does that change anybody's mind? Right? That's the point that I'm trying to make. That's, you need to look at this in a clinical context. So we as a specialist have the clinical intuition that if majority of you agree, this person smells like MASLD, but people who actually do the screen in primary care don't have the sixth sense. So what do we do? And you've seen this, this is AASLD guideline. You use FIB4, if is 1.3. It's been said that it is developed to rule out advanced fibrosis. That is true. But the guideline, the way it is used as a rule-in for moderate fibrosis. Because if your FIB4 is greater than 1.3, you're directed to have FibroScan. And that's what the guideline recommends. So I'm going to come back to this data. The randomized trial was done, right? And a large proportion of, a whole lot more people got tested, and primary endpoint was met. But if you look at sort of under the hood and how FIB4 helped diagnose fibrosis is the graph at the far right. 56 people got sent for FibroScan, and 19.6% were found to have fibrosis. In the standard care, 5 people were sent, small number, 1 person was found to have fibrosis. They are 20% exactly the same, which is what's expected for a diabetic, unselected diabetic people. About 20% have fibrosis. The meaning that this trial sent a lot of people to go get FibroScan, but it was done in a random fashion. FIB4 did not enrich that population to have higher detection of moderate fibrosis. Does that make sense? So that if the goal of the first line screening is to make sure that we have higher proportion of people that will test positive, in this particular data, which is the only randomized trial that I'm aware, failed to do so. That's point number 1. Point number 2 was made by Dr. Bansal earlier, that if you look at the adherence of people going to FibroScan, this is the prominent liver group in Hong Kong that is very well known. And they did a study, randomized clinical trial. Patients were watched like hawk, and they were sent to FibroScan. Only a third showed up. So just throwing out a guideline says do FIB4 and send to FibroScan. The actual result of that is this. So out of 533 diabetic patients that were randomized to intervention, only 11 got diagnosed with fibrosis, 2%. The expected prevalence is 20%. they found 2%. So majority of people still are not diagnosed. So it's one thing to do a study and one thing to recommend to do stuff, but we really need to make sure that we think through what we do to make a difference in our patients' lives. So a little comment on FIB-4. I try to talk a little bit about this item. If you think about the formula, age divided by platelets and AST and ALT ratio, you immediately recognize platelets and AST-ALT ratio are cirrhosis markers. If you're a hepatologist, there's no sort of a combination of AST and ALT ratio that will differentiate from F0 and F2. You can't tell that. And platelets don't start to decrease significantly until you have advanced fibrosis. So to think that somehow by amalgamating these variables, you will be able to pick up moderate fibrosis is a myth. So I made this point, and it is validated by Richard Sterling, who wrote an editorial that said FIB-4 turns 20, a lesson of serendipity. He said, given the limitations of FIB-4 and other available non-invasive tests, we need to move beyond simple tests. And he seems to be recommending a thing called SAFE score. And I have a conflict of interest, as you know. This is a score we developed. So this is a score that we customized for MASLD. In addition to FIB-4 variables, we added BMI, diabetes, and total protein albumin. And if you go to MD Calc, you can do this. And this is the data that's presented in the calculator is the patient that I presented, the 55-year-old diabetic patient with colonoscopy. And our score says 107 is a high tier for F2 fibrosis. Again, I just made up these numbers to make a case, so no big deal. So the last piece of data I'm going to share with you is an abstract that we presented at AASLD. I thought this would be of some interest to you guys, the younger people. So this is a generative AI research that was done to simulate population screening. So you've seen this dog pictures on the internet. The way they do it is you train a generative AI model based on a bunch of dog pictures, and once it is trained, it can generate millions of dogs that are not real dogs, right? You can do the same thing with clinical data. So it's called a denoising diffusion probabilistic model. You feed a patient's data. This happens to be enhanced data, as shown here, type 2 diabetes and so forth. And it goes through the same process of noising and denoising. And at the end of the process, you get a bunch of data of people that are not random, but that has the relationship, biological relationship of these variables that are coherent and intact. So these are sort of a real people that can happen, and you can generate millions of those individuals. So we did a trial comparing FIB-4 and SAFE score, and the detection of fibrotic MASH was 6.5% with FIB-4, 15.6% with SAFE. The point I think is important is that if you think about treatable MASH, the moderate, middle stage, F2, F3s, SAFE is targeted for that stage, and it does much better than FIB-4, which looks for advanced fibrosis. So 3 times as many treatable MASH, and that decreases number to screen to find one person treatable from 30 to 10. So who to screen? Current challenge is too complex and heterogeneous, and that therefore it's not practiced. We can use data-driven approach. I showed you type 2 diabetes and obesity. With or without hypertension covers most people with fibrotic MASH. How to screen? There is weak evidence to support FIB-4. SAFE is an alternative. Importantly, one size may not fit all of these. But the bottom line, I think, is many opportunities of research exist, need high-quality data, randomized clinical trial data that what we do matters. So what's take home? Need more evidence-based data. I said it too many times. Screening is done by primary care, fibrosis as a surrogate marker. We need to educate them that concept, and we need to keep it simple. Uncertainty about what test to recommend, limitations of FIT4, we talked about that. SAFE may be an alternative, but there are others. But the problem is none of them are perfect. You don't have 100% sensitive test. So you need to customize based on your own setting. What is your prevalence? If you have a very high prevalence setting, you may not have to deal with FIT4 SAFE. Go directly to FibroScan. There's nothing wrong with that if you have very high prevalence of MASH. If you're concerned about patient adherence, make it simple. Don't do 2 steps. Do 1 step. And if you don't have availability of elastography, you have to figure out something. So just because guidelines says do this, that's not the gold standard. You need to adapt to your own practice because the evidence that supports the guideline is not that strong. So thank you very much for your attention.
Dr. Kim, thank you very much for this excellent speech. As a teacher approach, we will get the question and comments at the end of the session. Our next speaker is Dr. Zeybel. His topic is Care Muscle D. Please, Dr. Zeybel.
Good morning, dear chairs and colleagues. Thanks to the organizing committee for kind invitation. I will try to wrap up the management of the muscle D. It's a hot topic, but it's a difficult task for me because it's covering so many different aspects. I will try to stick on the guidelines and the evidences on this field. So, after the introduction of new terminology for steatotic liver disease and muscle D, and new definition and new cardiometabolic criteria and diagnostic criteria, I think the muscle D field, both in clinical and research, this field has transformed. But the treatment goals are more or less same. Like in any clinical condition, we try to reduce the mortality related to this clinical condition and morbidity. We got some liver-related outcomes. We try to delay or prevent decompensation, decline in liver function, and progression to cirrhosis, and ACC incidence in this population, and need for liver transplant. Obviously, muscle D is associated with many cardiometabolic risk factors, and prevention of the other conditions related to muscle D, such as cardiovascular disease or extrahepatic malignancy, is also important. And quality life is obviously another important issue. But in terms of surrogate endpoints, as Dr. Kim explained very well, the most important prognostic indicator for muscle D in other liver disease is fibrosis. So I will provide you some data, and afterwards I will try to move to the treatment of muscle D. So this is a nice study, including 2 clinical trials. You see that regression of fibrosis has been associated with reduced risk of liver-related outcomes. This blue bar is representing patients who had regressed fibrosis, and the big bar is the non-regressed fibrosis patients. So therefore, regression in fibrosis is related to liver-related outcomes. And another study, this shows that improvement in NAS score, steatohepatitis, or resolution of steatohepatitis, has also been associated with regression of fibrosis. And later on, another study regarding the steatosis, relative decline in MRP-DFF, steatosis more than 30%, is also associated with fibrosis regression. And relying all these data from regulatory perspectives, FDA and EMA has been set for phase 3 clinical trials 2 major surrogates: resolution of steatohepatitis without worsening of fibrosis, and regression of at least 1 stage in fibrosis without worsening of steatohepatitis. So from the treatment aspect, I will also mention all these important points. But we can't get liver biopsy for every patient for monitoring the disease activity. So now we got non-invasive tests. We got transient elastography, FIB4, and as you see here, another important surrogate reduction in PDFF and ALT reduction is also been associated with steatohepatitis. So we can use non-invasive tests nowadays instead of liver biopsy in our clinics, but in phase 3 trials, still in many trials rely on liver biopsy. So non-pharmacological therapy has been mainstay of the treatment in muscle D for many years. There's a clear data that if we, by dietary and behavioral therapy, induce weight loss, if we would like to decrease this hepatic steatosis, we need at least 5% of the body weight loss. For the steatohepatitis, 7 to 10%, and fibrosis regression, we need more than 10% of the weight loss. How are we going to do this? This is an issue, and it's a very difficult task. The data regarding the different diets is not so robust, but from the different clinical conditions and muscle D as well, Mediterranean diet looks the best option so far. But we also, including data from obesity and diabetes, we limit ultra-processed food. We also ask patients to avoid soft drinks. And from different parts of the world, we got data that coffee consumption is associated with reduced risk of chronic liver disease, including muscle D and fibrosis. And there are typical questions from my patients. I don't know how you answer. Is Turkish coffee protective against muscle D and hepatic fibrosis? I do not know. If we boil it, it may be different. We don't know. But all the other coffees seems to be effective. And we encourage physical activity and exercise. So more than 150 minutes per week of moderate intensity exercise, or more than 75 minutes per week of vigorous intensity exercise, we encourage patients to apply this in their lifetime. And as well as that, there are short-term studies. By this exercise, there's a reduction of steatosis, and 12-week aerobic exercise study shows that there's improvement of fibrosis and ballooning degeneration in hepatocytes. And later on, after setting all these rules by FDA and EMA, we started to get phase 3 trials for the registration and licensing purposes. This was the largest phase 3 trial of obeticholic acid, which is an FXR agonist. Shows some response in improvement in fibrosis. You see here compared to placebo, but there wasn't clear effect on NASH resolution, and there was a concern regarding the safety of the medication. You see the very high pruritus and increase in LDL cholesterol, and FDA chose to not go ahead with the approval of the obeticholic acid. But 2 years ago, resmetirom, which is a thyroid hormone receptor beta agonist, showed very promising results. You see up to 30% of reduction in NASH resolution, and up to 26% in fibrosis improvement in this patient group, and as well as LDL reduction. And safety-wise, it was promising as well, and FDA approved, and AASLD published this practice guidance how to use resmetirom in patients with muscle D. Unfortunately, it's not available in Turkey, but it's advised to use in VCTE measurement by 8 to 15 kilopascal, or F2 to 3 fibrosis. And they advised to monitor the response in 12 months and every 3 months. And if there's a more than 25% of reduction in liver stiffness, then it's a beneficial response, you can continue to the treatment. If it's less than, you can either choose other alternatives or you can re-evaluate this strategy. As I've got only a couple of patients from the US that they come to Turkey for follow-up, and I see their side effects and other problems, but it is very important colleagues in Turkey know that if patient is on clopidogrel, we need to adjust the dose. And for the statins wise, there's a maximum doses. There are some alterations, then we need to be careful about this. As far as I understand, the diarrhea is not the main issue in this patient's group, self-limited, and even gallstones are not contraindication for resmetirom, and there's only one case of hepatotoxicity I found in the literature. As many patients show fluctuations of thyroid hormones during the treatment, so monitoring the thyroid hormones can be important. And if you reduce the dose of statins, I think you need to reassess cardiovascular risk during the treatment for this patient group. And last year, semaglutide, GLP-1 receptor agonist phase 3 trial results published. You see with semaglutide, resolution of steatohepatitis up to 63% of the treatment and in the patients, and the reduction in liver fibers up to 37%. And compared to placebo, it was very significant. Semaglutide is available in Turkey and Europe, and we know their GI disturbances, nausea, vomiting, diarrhea, constipation, and many patients tolerated well this medication. There was an increased risk of gallbladder diseases, gallbladder stones in this patient. I will tell you about this. And just after this publication, FDA approved this medication, and again, AASLD published this practice guidance. I think we need to go through this carefully together because it's available in Turkey. Wegovy is available as well. So the ideal patient for semaglutide is liver stiffness measurement of 8 to 15 kilopascal, but 15 to 20 kilopascal patients can be treated with this as well. Or if there's a histology, F2 to F3 fibrosis patients can be treated. And the response assessment for semaglutide is at 72 weeks, is slightly different than resmetirom. If there is more than 30% of the reduction in the liver stiffness, you can go ahead. But if there's a subthreshold improvements, you've seen the data on one of the meetings, so there could be weight-independent effects, then you can choose to continue or choose other options. But if there is a worsening or the progression of fibrosis, then we need to call the medication. I think the safety concerns-wise, we need to discuss it very well. One of them is the acute kidney injury, as vomiting, diarrhea, and many problems. We need to be careful, and we need to encourage adequate hydration for these patients. And reassessed renal function can be important in this patient group. If there's a suspicion of acute pancreatitis, we need to halt the treatment. And for the gallbladder disease, in the clinical trial, there's a significant increase in the incidence, and we need to educate patients regarding the biliary symptoms. And if there's a bile stone, gallbladder stone, I avoid this medication in my patients, but I know there are different approaches. And in AASLD guidance, it says there's a caution in this patient group. There's obviously it's contraindicated in medullary thyroid cancers and MAN2 syndromes. And I see some of endocrine specialists in Turkey, they do routine calcitonin testing. It is not advised by AASLD to do routine calcitonin testing. And if patient is in insulin or sulfonylureas, we need to inform the patient regarding the risk of hypoglycemia. And there's a small risk of chronotropic effect, so we need to be cautious in arrhythmia-prone patients as well. I think we all seen this gastroparesis and delayed gastric emptying time in these patients, especially when we start these medications, when patients turn off for the upper GI endoscopy in the morning, we ended up with full stomach, and we were quite scared of the aspiration risk. So we need to be very careful regarding the surgery and the endoscopies for these patients. The guidelines suggest no major change, no holding the treatment. For instance, I ask my patients to have just a liquid diet just a day before the procedure to avoid this problem. And ocular complications can be also important. We need to avoid rapid glucose lowering in this patient group. And another important, especially in cirrhotic patients, the loss of muscle mass is important. We know that 1/3 of the weight loss is from muscles, so we need to encourage resistance training and provide enough protein in this patient group. What is in the pipeline? There are PPR agonists, another GLP-1 and glucagon agonists, FGF21 agonists, and FASN inhibitors. In Turkey, we are involved in 3 of the clinical trials, both in F2, 3, and cirrhotic patients, and we are really looking forward to have more choices for these patients. We hope that it will be promising results from the phase 3 trials. What about bariatric surgery? The indications for the bariatric surgery is not different in non-cirrhotic muscle D patients. According to BMI and associated comorbidities, we make the decision of the bariatric surgery. If you look at the data, it's very promising. This was studied by Matrin et al. You see in 5 years' time, the reduction of the fibrosis in the majority of the patients, and recent randomized clinical trials showed that NASH resolution in up to 57% of the patients, and the improvement of at least one stage of fibrosis up to 39% of the patients. But it's a surgery, there's a morbidity, small, but some mortality in these patients as well. If patient has compensated cirrhosis, then the indication and type of surgery should be discussed in multidisciplinary team meetings. If, for instance, there's a risk of decompensation following gastric bypass surgery, I think this should be very carefully discussed with the patient as well. In terms of muscle D cirrhosis, what's the difference in the management? I think we need to be careful about the weight reduction in this. We need to encourage moderate weight reduction and provide high protein for sarcopenia. In terms of metformin and sulfonylureas, we advise not to use in decompensated cirrhosis. GLP-1 receptor agonist, there's a controversial data. It can be okay in child A, but we need to avoid in child B and C cirrhosis. SGLT2 inhibitors we can use in child A and B cirrhosis. Statins, we need to make the decision according to cardiovascular risk. It is okay to use even in cirrhotic patients. Regarding portal hypertension, we use Boveno criteria for clinical significant portal hypertension. More or less is similar to the other indications. Just to rule in over 25 kilopascal of liver stiffness is not very accurate in this patient group, but we need to recommend upper GI endoscopy if stiffness over 20 kilopascal and or platelet count is 1 in 50. So, conclusion. The last 3 years has been remarkable for muscle D research and the clinical applications. There are new medications, there are more in the pipeline. I'm sure we will have more choices, but the mainstay of the management is still lifestyle changes. We need to underline this. Widespread use of liver stiffness, non-invasive tests, and clinical care pathways is making this, is helping patients and us in this matter. And the new clinical trials relying on non-invasive tests and liver stiffness will probably make us some easier ways to treat and help these patient groups. Thanks.
Thank you, Dr. Zeybel, for outlining the critical aspects of patient care. Now we have reached the final and interactive part of our session. We will proceed with a case-based panel discussion, followed by a Q&A session for all our speakers. I would like to invite our case presenters. We will start with Dr. Filiz Aras to present her case.
Dear session chairs and colleagues, it's a great honor to make this presentation here, so I would like to thank organizing committee especially for this opportunity. My case is a 53 years old female patient. She presented to our outpatient clinic, gastroenterology outpatient clinic, with elevated liver tests. 6 months ago, she had completely normal liver tests. 1 month ago, before coming to gastroenterology clinic, during an endocrinology visit, patient reported some symptoms, including myalgia, fatigue, and weakness. At that time, elevated liver enzymes were detected. She has no history of alcohol consumption, no hepatotoxic drug use, or no use of herbal or dietary supplementations. This slide shows laboratory follow-up before presenting to gastroenterology outpatient clinic. During over 1 month, ALT and AST levels remained as high. ALP and bilirubin levels were within normal limits. On her past medical history, she had a diagnosis of hypertension for 4 years and being currently treated with angiotensin receptor blocker. She had also autoimmune thyroiditis under follow-up without medical treatment. She is a non-smoker. Also, her family history is unremarkable. On physical examination, BMI was 23.6 kilogram per square meter. Waist circumference was 78 centimeters. Cardiopulmonary examination was unremarkable, and abdominal examination was normal.
Sorry to interrupt, but let's pause on this slide for a moment. I would like to ask the audience or our experts, what do you think about this case? Please, Dr. Benson.
Yeah, so obviously it's very interesting that they were normal before, and then this is rather acute-ish, right? Acute kind of elevations that are here. Also, I was struck by her low waist circumference and low BMI. So, you know, we talked about, Ray mentioned waist circumference. She really doesn't have visceral adiposity or risk factors for overweight or obese, and she's, I think you said, does not have diabetes either. So it's
No
just
diabetes.
hypertension. A little bit not the classic MASLD presentation.
What do you think about the subacute onset of fatigue, myalgia, and weakness for the patients? It lasts 1 month duration.
Yeah, I mean, I think that seems to be maybe a muscle connection here. I was thinking like a lipodystrophy, some kind of acquired lipodystrophy where you have loss of muscle mass, but then you have potentially steatosis in the liver. If you do or not, you'll tell us.
When we look at the lab pattern, we notice that the hepatocellular pattern of injury on ALT and AST ratio is more than 1, which typically suggests hepatocellular injury. Do you think this patient may have still the muscle injury, although the AST level less than the ALT? The source of transaminase,
I mean, I think it's worth checking CK, but I think there's also liver injury here.
Did we check the CK levels for this patient?
No. No.
Okay. And the patient have normal bilirubin and ALP. It suggests no significant cholestasis. And do we know What type of, yes, please.
At this point, I mean, the healthy woman who was normal blood tests a couple of months ago,
Yeah.
and BMI is normal, and she has hypertension, and rather than that, she doesn't have any comorbid situation. What we know is she has autoimmune thyroiditis. When a patient like this come to clinic with ALT and AST elevation, what I first think is autoimmune hepatitis or a viral infection.
Yes,
And
I totally agree with you because the autoimmune thyroiditis is a crucial clue for these patients. The presence of one autoimmune condition may increase the likelihood of another autoimmune diseases, for example, the autoimmune hepatitis. When we check the IgG level on the slide, it's also totally normal, but we know also that maybe 10 to 20% of the all autoimmune hepatitis case may be seronegative or with normal IgG level. What do you think about this?
we should rule out any herbal medicine or any medical medicine consumption. Sorry.
But during the medical history, I noticed that there is no any herbal using, right? Yes. No alcohol, no distinct hepatotoxic drugs. Candacertan is generally safe, but it may cause still delayed reaction, drug-induced liver injury. But the patient was on candacertan for many years, I think.
4 years.
Yes, 4 years. It may still become, but it's unexpected, I think.
Well, I will go on for herbals and those stuff again and again to rule out any hepatotoxicity. And if ALT and AST levels are still on with these blood results, even IgG is normal, I will go for biopsy.
What about the viral hepatitis for this patient?
Well,
Chronic
I have to
or
check.
acute or something like that?
Yeah, I mean,
Although hepatitis B surface antigen negative and anti-HCV is negative.
we have to check IgG. I mean, nowadays, as this is a Turkish lady, it's very rare to have occult hepatitis, but still it's on the table. It's good to check DNA level before doing the biopsy.
Based on these findings until now, our differential diagnosis should prioritize first autoimmune hepatitis because the patient's 53 years old female. There is some symptoms.
Do we have
weakness.
autoimmune markers? I didn't see alpha smooth
I think
ASMA.
Not yet, I think.
Not yet. Oh, not yet. Oh,
We don't know. But maybe viral. What about hepatitis E, for example? I'm just confusing.
First,
Yeah.
we have to follow up the patient if the ALT and AST levels are still on. For example, 4 weeks passed, 6 weeks passed, 8 weeks passed. And I think when we have the autoimmune antibody results negative, I will go for biopsy to
Do you think
explain.
that the patient may have muscle, although her body mass index was totally normal?
She's Turkish lady. And with these blood results, it's unlikely.
Yeah.
Unlikely.
Another comments from another audience, experts?
Can be lean muscle. So, but we have to work up not get.
Yes, you are right, but there is a symptom.
Hepatology workup, and after that we have to give
Yeah.
what's this.
Yes, you are
And-
totally right. I agree. But the patient was totally normal with lab and with not asymptomatic before. The symptom
Yes.
just started 1 month ago. That's all
And
right.
any hepatomegaly on physical
Yes.
examination?
We will see. Let's continue, please.
I would like to say that those symptoms were self-limited and they resolved in few weeks. Most probably it was not documented, but most probably it was associated with viral infection. Autoimmune hepatitis was first diagnosed to be excluded, so we studied the autoantibodies which were all negative. And abdominal ultrasound revealed grade 1 to 2 hepatic steatosis. Here, can I go on? Patient with normal BMI, no diabetes, with blood pressure, has blood pressure and a little bit elevated, a little bit high triglyceride levels.
Can we narrow down the etiology now with the new findings? There are 2 cardiometabolic risk factors for the patients and steatosis on the liver. What is the diagnosis now? Alcohol.
Etiologies. When did she have menopause?
2 or 1 years ago.
Yeah,
It's
so
postmenopausal.
often post-menopause, you see women start to catch up to men in many ways, including liver disease. So whether that's also playing a role here is possibility. Also, I mean, certainly Epstein-Barr virus, COVID.
yes.
I mean, these are all possibilities here, given the acuteness of the situation and the associated systemic symptoms.
Yes, weakness and fatigue is expected for fatty liver diseases, but myalgia not.
And not so acute. I mean,
Yes.
there's something changed here. I mean, this woman was walking around and all of a sudden she's not feeling well. So obviously some of the viruses that you may never know, but are there.
Yes. If we had any cardiometabolic risk factor for these patients, in this case, what would you
I would
think?
take biopsy, I think.
Okay, continue. Please go ahead.
We evaluated the fibrosis stage by non-invasive measures. FIB4 was calculated to be 1.21, and also NAFLD fibrosis score was minus 3.29. These values corresponds to low level of fibrosis. And then treatment approaches in this case for this patient included just lifestyle modifications, diet and exercise. Diet advice included decreasing daily calorie intake by 700 kilocalorie, and also Mediterranean cover or Mediterranean diet or plant-based diet covering vegetables, legumes, olive oil, and so on. As exercise, we recommended 150 minutes of moderate activity per week.
Sorry, I would like to ask the Dr. Ray, do you suggest the calorie deficient diet for this patient, normal body mass index? 700. Do you think it's too much for the patient?
I was just saying to Dr. Mansell that I would die on that diet. It's a tough case. I feel like there's more than one thing that may be going on.
Yeah.
And, you know, she had a normal test until very recently, and, you know, there's no, not that I know, acute MASLD, right? So MASLD has been around, maybe underlying for some time with a biochemical silence, but she has something added to that, and my bias is that, you know, it may be something that will resolve on its own, and maybe give a little bit of a time to see what happens before, you know, putting her through a very rigorous MASLD treatment. But that's only my bias. I think that's not very many Americans will follow this instruction, that I can tell you.
If you check the insulin resistance for this patient,
No.
but
I
you
don't
have to do it because, and you mentioned that there is no history of the family history, unremarkable. Is there any diabetes patients in that patient?
No.
in the
No
family
diabetes in her family.
members?
No diabetes in her family.
Because I think this is not autoimmune hepatitis. In the beginning, she can be lean fatty liver disease, and the diet is very much, I think, but lean fatty liver disease, weight loss nearly 5 or 10% can be useful, and we will follow this patient.
For lean muscle patients, we suggest to lose weight 3 to 5% for this patients group.
After 6 months of follow-up, she lost 5% of her weight, which was 3 kilograms. But ALT and AST levels over this period still remained high at the end of this period. Now, at the end of 6 months of follow-up, fasting plasma glucose level was 103 milligram per deciliter, and HbA1c level was 6.2%, now indicating the diagnosis of prediabetes. Here, LDL level is a little bit high, but HDL and triglyceride levels are normal now, and FIB4 was calculated as 1.2 again.
What about fibroscan results for the patient?
FibroScan?
Yes.
We don't have any FibroScan in our clinic.
Right.
This graph shows AST and ALT levels remaining high during 6 months of follow-up, and ALP and bilirubin levels were normal. We have 2D shear wave elastography, and we applied it. It showed liver stiffness measure compatible with F1 fibrosis, and steatosis pattern was shown as S3. We have magnetic resonance elastography and PDFF, and we applied this measure also to the patient. It showed 31% of steatosis, which accrues to severe grade 3 steatosis. Stiffness measure was correlated with F1 to 2 fibrosis. Now, in this case, we have a patient with normal BMI, having AST and ALT elevations for more than 6 months, hypertension, and now plus the prediabetes. We have one more comorbidity right now. Can I go on?
Is there any comment?
There's, the amount of fat in the liver relative to the rest of her body is really significant. So I come back to that idea of like a lipodystrophy, where there's abnormal deposition of fat preferentially in the liver. Why, I don't know, but just acquired lipodystrophy.
We also know the HIV serology for this patient.
HIV?
Yes.
No.
You are continuing?
Okay.
Okay.
We go on with diet and exercise recommendations, and she was PPR gamma agonist was prescribed on endocrinology polyclinic or endocrinology outpatient clinic to the patient. 6 months after treatment with pioglitazone, ALT and AST levels were normalized.
Just before starting the pioglitazone, are you pretty sure regarding the diagnosis? Why don't you take another action, for example, the liver biopsy for the patients? Because it's not a typical lean patients also. Maybe.
Did you check the leptin level for the exclusion of the lipodystrophy and Tanita examination?
No.
For the detection of the abdominal accumulation of the fat?
We don't have a leptin measure.
Okay. Yes. A microphone, please.
I think before going to treatment of this kind, not established treatment, I mean, it's not already accepted by the FDA or the guidelines. you need to have the biopsy. Maybe this patient, you cannot rule out, maybe this patient may be seronegative autoimmune hepatitis as well. Maybe anti-liver soluble antigen antibody may be positive. So I think you need to go to biopsy before starting the treatment.
It's fast.
Yes, please.
Very good case. Thank you for your presentation. I saw these kind of people, and I am also treating these kind of people with pioglitazone. And we also have data about it. So we found that fibrosis could be stopped by using pioglitazone. The people who are using pioglitazone as a subgroup analysis, they didn't go to cirrhosis, and we could show that the fibrosis can be stopped by pioglitazone. So F2, F3, but our patients were all biopsy proven. The only point, I think the leg point that is the patient is that should be biopsy proven. After biopsy, you can start pioglitazone and you can get very good results. And I saw these kind of decrease in ALT and AST levels, such kind of patients. Thank you.
Please proceed. Yes.
After 6 months of treatment, ALT and AST levels were normalized. Fasting plasma glucose level was 92 milligram per deciliter. 554 was lower than 1. But now patient has BMI of 25.2. She gained 6 to 7% of her of body weight. Then they stopped the treatment 6 months after discontinuation of pioglitazone. Patient still has BMI of 25.6. Now it's over 25. She's unable to give weight anymore. Fasting plasma glucose level is 94. HbA1c is 5.7%. And AST is normal, but ALT is a little bit slightly, it's increasing slightly, but still lower than the upper limit of normal. Lipid profile is normal. Here we had elastography measures showing liver stiffness measured as 6.1 kilopascal, which equals to fibrosis 0 to 1, but severe steatosis, but the measurement was compatible with severe steatosis. Now, according to the non-invasive test, patient has low, insignificant fibrosis levels, but severe steatosis, but not able to give weight, but normal ALT levels at right now. What would be the next step?
Yes. Yes.
So it seems that the liver enzymes stayed about where they were, even though we eliminated pioglitazone, which means one of two things: they were getting better on their own, and the pio had no impact. There was a viral, resolving potentially viral illness superimposed on underlying MASLD is possible.
Yes. Thank you.
Thank you for your attention.
Thank you for your presentation. The second case will be presented by Dr. Zeynep Melekoğlu Elik.
Good morning, dear chairs and colleagues. Thank you for the opportunity to present our case today. Our patient is 74-year-old female with chronic liver disease since 2013, presenting for routine follow-up. She has diabetes mellitus and hypertension. Family history is unremarkable. She doesn't have any history of smoking or alcohol consumption. She uses metformin and amlodipine. On physical examination, her body mass index was 25.4 kilograms per square meter, and there were no remarkable findings. When we look at the laboratory findings, INR was 1, AST, ALT, and other liver tests were normal. AFP and CA19-9 levels were within the normal range, and 5-4 score was 5.9.
Sorry, can I ask for the patients, what is the main risk factors for the patient regarding advanced chronic liver disease or hepatocellular carcinoma for these patients? What is the risk factors you can notice? Age, yes. Diabetes, and gender, yes. Another comment? Thrombocytopenia, yes. The patient admitted to the hospital, it was under follow-up,
For routine follow-up, yes.
but there is no any story during the follow-up before. It was
no.
following up
We,
by another
yes, we
hospital?
following up her for chronic liver disease.
I see. But you are aware that the patients had advanced fibrosis or cirrhosis before?
Yes.
Oh, okay.
Can I go?
Yes, please.
All autoimmune and viral serologies were normal, negative, pardon. In 2013, abdominal ultrasound revealed mild hepatic steatosis.
Sorry, I think in these cirrhotic patients, anti-HP core IgG positive.
Yes. Negative.
You check it.
Yes.
Do you suggest vaccination for hepatitis B for this kind of patients? Do we have any information about it?
Yes, we
Do-
suggest.
If HPV DNA negative, yes.
Yes. Okay. Yes, please. Isolated IgG positive, yes.
This patient is already faced with HPV virus, and there is no antibody,
Yes.
but I think vaccination is not going to work here.
Okay, that's the question I want to ask. What about, did you check other serology for hepatitis A or E for the patients?
Yes, we check all of them.
Anti-HAV IgG was negative or positive for the patients? If I mean that if it is negative, we should vaccinate to the patient for also hepatitis A. That's the reason I asked. Okay. Please proceed, yes.
In 2014, on transient elastography, the CAP score was 257 decibels per meter and fibrosis was 15 kilopascals. In 2022, dynamic abdominal MRI showed features of chronic liver disease and portal hypertension, and splenomegaly was present. She was diagnosed with metabolic-associated steatotic liver disease with stage 3 fibrosis. Lifestyle modification, weight management, and glycemic control were recommended.
Sorry. How we treat these patients? What about the lipid controls, for example? We only mentioned lifestyle medication and glycemic control, but we missed the hyperlipidemia for the patients. This patient was diabetic, hypertensive, but
Yes.
the LDL cholesterol level, as I remember, is pretty high, very far away from the target level for this kind of patients. The patient has diabetes, hypertension, advanced liver disease, and fatty liver. It means the patients had a high risk for atherosclerotic vascular diseases at this high risk. Probably very high risk, we don't know. We should lower the LDL level to below 70 milligram per deciliter if the patient had high risk patients. what is the treatment for the lipid levels for these patients? Do you treat statin cirrhotic patients? What percentage of our audience treat these patients, although the patient had compensated cirrhosis?
Yeah.
Who don't give the treatment?
I mean, she's 75 years old.
Doesn't matter, yes.
But this is back then. This is data from 2013, 2014.
Yeah, I mean,
So,
she was there.
yeah. Yeah.
Okay. Yes, we can go.
During follow-up in June 2025, dynamic abdominal MRI demonstrated features of chronic liver disease and well-defined lesion measuring 42 by 40 millimeters in segment 7. As you see the lesion in segment 7 here, the lesion showed arterial phase hyperenhancement followed by venous washout. It appears hyperintense in the hepatobiliary phase, consistent with HCC.
I am wondering whether the patient has a strict surveillance program or not.
Not, I think.
Sorry?
Yeah. Yes.
Yes, but if it is the 4 centimeters in size, it's a quite unexpected.
Yes.
I was expecting to detect before, for example, maybe 2 centimeters. How do you have any experience like this from our experts? Ah, okay.
Yeah. So you're saying that the patient was not enrolled in a surveillance program for HCC prior to this being found?
So she's on program.
She was, okay.
Yes,
So that's, okay. That's important because obviously people who have MASH are at an increased risk of developing HCC, even if they don't even have advanced fibrosis. In fact, the AASLD guidelines are likely to change in the next 2 years to reflect screening and surveying for HCC, even in diabetics who have F2 fibrosis. It's an important point.
Thanks.
Some guidelines, not all, suggest screening not significant fibrosis for advanced fibrosis at this stage 3 fibrosis. The AASL guidelines suggest to do it, but I also agree with you in my clinical experience. If the patients had more than one risk factors, for example, very long history of diabetes, elderly patients, maybe other risk factors for HCC, with a significant fibrosis, we should look at this patient very carefully. Maybe in academic institutions, not all the state hospitals, but we should be careful about this because we know that non-cirrhotic patients may be complicated with HCC also, like hepatitis B virus.
And actually, ultrasonography is operator dependent. Most likely, this lesion missed. That's why when we follow the cirrhotic patient, we do CT or MR. I do generally, initially and in every 3 years to see what's going on in there. And when look at the MR, the appearance of the liver doesn't show the undulation. I would like to get the opinion about that, Dr. Mushturay. What's your opinion? When you look at the MR of this patient, could you say this is the cirrhosis or chronic liver disease?
Yeah, it doesn't look like, there is definite irregularity, but this is kind of a common occurrence in our practice. I mean, after adding elastography, ultrasound, or MR-wise, we're seeing normal-looking livers very stiff. So I think when you look at the textbooks or the old, school things, the irregularity comes late. Also, I mean, caudate is slightly, and you can see the elastography. I mean, the red areas, it's very easy. So I'm going to touch on that in the next coming session. I think this was a black box in liver because we thought that liver was normal on ultrasound or regular CT or regular MRI. Definitely you have to do stiffness measurements. I mean, we're seeing a lot of normal looking livers which are very stiff. So the baseline cirrhotic features on ultrasound, CT, MRI 10 years ago is no more, I think, valid today.
Thank you. Go ahead.
MR elastography showed a liver stiffness of 3.6 kilopascals. Endoscopic examination, no varices on upper gastrointestinal endoscopy. On FDG PET, no pathological uptake was detected. Multidisciplinary tumor board decided and recommended surgical resection. Yes.
This is a cirrhotic patient, and the endoscopy shows no varices. It's an important clue of the patients have no any clinically significantly portal hypertensions. Can you think that we may do if the size lower than 2 centimeters? What do you recommend for these patients? Yes, please. A microphone, please.
In my opinion, excuse me.
Sorry, radiofrequency ablation maybe if it is less than 3 centimeters, we can recommend for this patient.
We can also recommend resection.
Yes, resection is a good choice, but we can do it. We can discuss in the tumor board with other people with the other second disease or the general health of this patient.
Mm-hmm. Who used the fibroscan spleen stiffness to rule out or rule in the clinically significant portal hypertension? Yes, please. Your experience.
Hypertension for, we are using fibroscan for it to exclude and include, and we are using the limits, cutoff limits of the guidelines, and more than 15 kilopascal, and with less than 150 platelets. That shows us the patient has esophageal varices. So we are using fibroscan for detecting, and also the people follow up. We are using it.
Dr. Bansal, do you believe that the spleen stiffness may be a better surrogate marker of the absence of clinically significant portal hypertension?
Well, I'm concerned this patient's platelet count is 91.
Yes.
So that right there, to me, is a red flag for significantly portal hypertension. So I don't know on the imaging if you may not see endoscopically esophageal varices, but if there's paraesophageal, gastric varices, etc., it would be a high risk in a 75-year-old patient for resection.
Please.
In my opinion, the locoregional therapies for this hepatocellular carcinoma is a better choice than surgery, because she has cirrhosis and platelet levels less than 100,000, and the decompensation risk is very high. Therefore, my first choice is locoregional therapies for these patients.
I think the sites thought that the patient's child A and no any sign of portal hypertension, they take to the patient to the operation. Professor Ramazan Edilman, do you have any comment about it?
I mean, the tumor board decided and recommended the surgery because the patient bad condition and performance status grade 0. And we talked about the patient, and we showed all opportunities, and patient accepted surgery. and she went to surgery. But the point is, I guess, the MR elastography and also sonography show not kind of cirrhosis, but surgeon, when he saw the liver, is much worse than what MRI showed that, because the MRI showed that 3.2 kilopascal, but this more than 3.2 kilopascal.
But we don't use the fibroscan alone. If it, as I remember, it was 15 kilopascals.
15 kilopascals.
With the clinical history and the lab findings, we can say the patient have definite cirrhosis with the fibroscan results. Sometimes we cannot say if she has a very different lab results. We use all the findings all together and make a comment. What about transplantation for these patients? She is at the age of 74?
Yes, 74.
What is the life expectancy in Turkey? Why didn't take the patients to the liver transplantation directly? Yes, please. Dr. Josh.
Yeah. So my first question would be why this patient has thrombocytopenia without any signs of portal hypertension in the radiologic imaging. But to be honest, with these low liver stiffness values, I would approach to this patient as still with a patient who has cirrhosis plus clinically significant portal hypertension. And to identify that, we should perform HVPG measurement just before deciding which therapy to go. If the HVPG is not feasible, the best alternative for deciding on surgery or ablation, so this is a bit large for percutaneous ablation, so the ablation therapy would be transarterial radioembolization with the radiation segmentectomy, which would provide almost similar 5-year-old survival rates if you can directly target that segment. So the alternative of HVPG would be indocyanine green 15 test. So usually surgeons prefer that. So if you have an HVPG above 15 millimeter, so probably surgery is not a good idea, but we should discuss this with the surgeon. Maybe they would say that they would approach with a minimally invasive procedure. So if they could approach with a minimally invasive procedure, still we cannot say that clinically significant portal hypertension is not the absolute contraindication for surgery, but we should discuss with the surgeon.
Thank you. Actually, in the tumor board, when look at the MR of this patient, there is not undulation. Although this is not the rule out cirrhosis in this patient, a surgeon wants to do minimal invasive surgery in those patients because of age of the patient. Do not require transplantation generally over 70. I recommend the surgery if surgeon wants to take. If it doesn't, or the presence of the undulation and the clear-cut cirrhosis in the MR and the other test, then we will go local regional therapy. It's very successful, sometimes equal to the surgery. My point is that in the board, I recommend surgery if the surgeon wants to do minimal invasive surgery.
In the context of liver surgery, patients without clinically significant portal hypertension lower the post-hepatectomy liver failure and decompensation. But if we had a spleen stiffness evaluation for the patients, I believe that the patient has portal hypertension. The patient also had enlarged spleens, splenomegaly.
Yes, splenomegaly.
Yes.
I would like to ask a question here. Dr. Mushtaray, there is a big spleen. MR doesn't show portal vein thrombosis. Do you recommend portal Doppler ultrasonography to further evaluate the portal system?
We look at the portal venous Doppler in our hospital, but if it's patent, there's not much you can tell apart from that. I mean, and we're always doing MRI.
MR is enough in this setting?
Yeah, MRI. I mean, we rely on the MRI findings. And regarding this case, I think the elastography findings, which it was heterogeneous. If you Measure overall, it's 3.2 kilopascals. But if you see that, and also extreme red areas, those are red areas at least 5 kilopascal or 4 kilopascal, then you should suggest the diagnosis of not mild or moderate to severe cirrhosis. That's our experience with elastography. So fibrosis is heterogeneous in the liver, and we definitely see that with elastography also. So it's a little bit experience related. And regarding the treatment for these patients, if the patient is not in our hospital, this is kind of different than United States. If you try to do radioembolization to your patient, it costs a lot. But in our country, it's almost free. And interventional radiology is extremely developed, so it can be done in any university or hospital. So that's why we're using radioembolization a lot compared to surgery, because in my experience, it's really less harmful, and the results are unbelievably good. And it takes only 1 day to treat the patient.
As a transplant surgeon, I felt this urge to speak about this case. Actually, we do transplant those patients up to the age of 75 if everything looks okay. But while evaluating the treatment options, we never look at the recurrence rates. So the recurrence rate after resection is 40% in 2 years and 75% in the next 4 or 5 years. So what are you going to gain by resecting this tumor? So you need to be as minimal as possible in a patient at the age of 74. But on the other hand, you have to plan what are you going to do when there will be a resection. So are you going to re-resect? Very unlikely. So either do the best thing, if the patient is tolerable, do the transplant. So this is a living donor liver transplant country, and of course we give our decisions with discussions with the family. But if you are not going to transplant these patients, do the least invasive treatment, in my opinion, because this patient is very likely to have recurrence in the coming years.
Thank you for your comment. Yes.
She was admitted to hospital in October 2025 due to with abdominal bloating. Postoperative Doppler ultrasound revealed a partial portal vein thrombus measuring 13 by 8 millimeters with residual flow. What is the next? Okay. At this point, therapeutic anticoagulation with low molecular weight heparin was initiated. 3 months later, follow-up Doppler ultrasound demonstrated regression of thrombus with recanalization of the portal vein. How long should we continue anticoagulation?
At least 6 months, I heard.
Thank you very much for your attention.
Okay, the time is up. We need to move up to other symposium. It is a satellite symposium. Current perspectives in HCC, prevalence and imaging innovations. It will be moderated by Professor Ramazan Idilman, and the first presentation also will be done by Professor Ramazan Idilman.
Thank you very much.